Hello, I'm Gershon Davis. I'm Professor of Cardiovascular Medicine at the University of Central Lancashire, and I'm also a consultant cardiologist at North Cumbria Integrated Care NHS Trust. Thank you very much for watching this presentation on COVID-19 and the heart. Like so many of you, I'm involved in clinical settings where patients with COVID-19 are being investigated, treated, and managed. Whilst I have no disclosures for this particular presentation, I feel it is important to note that this is a fast-moving area and the evidence base for managing this condition is growing at pace all the time. The United Kingdom is affected by the novel coronavirus disease called COVID-19, and this is due to the global spread of coronavirus 2, also called SARS-CoV-2. In this presentation on COVID-19 and the heart, I will initially talk briefly about the virus itself and then move on to talk about the management and care of the patient without COVID-19 but has cardiovascular disease in the current era. I will then move on to talk briefly about differentiating COVID-19 symptoms from what is actually a presentation of cardiovascular disease, and then on to the patient who has COVID-19 and pre-existing cardiovascular disease. And finally, in the fourth section, I will talk about the patient with COVID-19 who has developed cardiovascular complications. The SARS-CoV-2 virus binds to cells via the membrane-bound glycoprotein called angiotensin-converting enzyme 2, commonly referred to just as ACE2. Once binding occurs, endocytosis follows, and other processes results in a release of SARS-CoV-2 RNA into the intracellular space. With further modification, new viral particles are synthesized. Physiological role of ACE2 is to cleave vasoconstrictor angiotensin 2 into vasodilatory angiotensin 1 to 7, and it's this association with the renin-angiotensin system that has sparked interest in the relationship of COVID-19, SARS-CoV-2, and cardiovascular disease. It's also important to note that SARS-CoV-2 has important clinical differences with some of the other viruses of the type. In particular, things like the predilection for myocardial complication, or for those with pre-existing cardiovascular conditions, or the worse outcomes in certain ethnic groups. In this first of 4 sections in this presentation, I will talk about the patient without COVID-19 but who has cardiovascular disease in the current era of the COVID-19 pandemic. I will talk generally about these patients, as you can see on the slide, and then move forward to talk about these patients more specifically in terms of those with underlying ischemic heart disease and acute coronary syndrome, those with arrhythmia problems, and those with heart failure. In the general management, as you can see from this slide, it's about limiting face-to-face contact and triaging of patients who have been referred to outpatient clinics and those on elective waiting list. Certainly, in most of the cardiac tertiary centers, procedural capacity would also be reduced. The key messages for ischemic heart disease is that primary PCI or PPCI is still the standard of care for patients with ST segment elevation MI. For those with non-STEMI, there may be some deferment in those who do not have high-risk features, but patients with high-risk features should still be offered invasive and interventional management. out-of-hospital cardiac arrests really need to be assessed on an individual basis. For patients with arrhythmias, only those with uncontrolled heart rhythm disturbances would be admitted to hospital. Similarly, only those requiring urgent pacemaker implantations would be admitted. All elective activity will be postponed. Interventional treatment for arrhythmias that are life-threatening would also be performed. In general, therefore, the principle is one of deferment of elective activity. For heart failure patients, it will be about assessing those with greatest clinical need, such as those with an NT-proBNP above 2,000 nanograms per liter. Just to mention briefly, and you can read from the slide, COVID-19 itself presents with variable symptoms, including fever, cough, shortness of breath, and it's important not to have cognitive bias in the sense that not all patients with symptoms suggestive of COVID-19 disease do have COVID-19. This is an illustration of a case in which the patient presented with some symptoms similar to COVID-19, but indeed had cardiovascular disease in the form of critical aortic stenosis, for which he underwent appropriate treatment. There's a high prevalence of cardiovascular disease and hypertension in patients hospitalized with COVID-19. In addition, these patients have higher case fatality rates and worse outcomes. The message here for clinicians is to be aware that these patients have a likelihood of more severe forms of illness, greater intensive care requirements, and worse outcomes. The fever associated with COVID-19 may unmask inherited cardiac conditions such as Brugada syndrome, which is associated with life-threatening ventricular arrhythmias. Some of the features are described on this slide with an ECG on the following slide. This is an ECG example of a type 1 pattern of Brugada syndrome. This and the following two slides deals with the patient who has COVID-19 and heart failure. What we do know is that there's a high prevalence in hospitalized COVID-19 patients. We know that they're less likely to survive hospitalization. We know that they tend to require a higher rate of mechanical ventilation. What we don't know is whether or not the heart failure is related to exacerbation of pre-existing LV systolic dysfunction, whether this is a new cardiomyopathy related to myocarditis, or is it related to cytokine storm. Treatment and investigations are similar to standard heart failure therapy. We'll talk further about investigations such as echo, but in terms of advanced heart failure treatment, this tends to be limited because of the uncertain prognosis. Heart failure itself is a clinical syndrome, but more broadly, cardiac injury has been described in the literature. And this ranges between 7 to 28% in hospitalized patients, depending on definition and depending on whether or not it's echo findings only. As with heart failure patients, it's associated with worse outcomes. There seems to be some time element in this, with cardiac injury occurring around 15 days, but certainly early cardiac injury has been reported even in the absence of ARDS. The mechanism of this cardiac injury, generally defined as raised troponin levels, is multifactorial, and the next slide will illustrate some of the possible causes. As you can see in this illustration taken from the article by Atri et al. In the Journal of the American College of Cardiology, it illustrates some of the multifactorial mechanisms associated with myocardial injury. Certainly, you can see the effects of likely type 2 MI related to hypotension, increased metabolic demands, and hypoxia, or type 1 MI, standard form of traditional MI related to pre-existing atherosclerotic cardiovascular disease and plaque rupture. In addition, microvascular dysfunction related to vasculitis and vascular endothelial injury, and fourthly, hyperinflammatory states associated with the cytokine storm. So there are at least 4 mechanisms postulated for potential mechanisms of myocardial injury. But certainly note that whilst type 1 MI may exist, type 2 MI is also possible. What about COVID-19 and arrhythmias? Similar to heart failure, arrhythmias are quite prevalent in hospitalized patients with COVID-19. It is certainly high prevalence in patients on intensive care units. Again, like heart failure, the mechanism of arrhythmia tends to be and is likely to be multifactorial. There may be inflammatory reaction affecting the electrical system directly, or arrhythmias may be secondary to other cardiac problems such as myocarditis, heart failure, or indeed acute coronary syndrome. From a practical perspective, if any of this degenerates into cardiac arrest, then certainly staff needs to ensure that they have full personal protective equipment. This slide shows 3 possible mechanisms of arrhythmias in patients with COVID-19: direct virus tissue invasion, overactivity of the immune system or cytokine storm, and most importantly, QTc prolongation related to medication and medication interaction. This slide illustrates one way of looking at a time course of the illness and what possible mechanisms may be associated with arrhythmia generation, thinking of the illness in terms of the early phase, a phase 2, and a later more complex phase. Following on from the previous slide, this current slide is a good illustration of the cardiac concerns that may be considered or be important in each of those 3 phases: the early phase, the sort of middle moderate disease phase, and the more severe form of illness. Following on from the discussions on arrhythmias and heart failure, it is worth noting that both troponin I and BNP or proBNP may be elevated and do not either specifically indicate a diagnosis of heart failure or acute myocardial infarction, respectively. Echocardiography may be useful, and transthoracic echocardiography should be carried out in accordance with the British Society of Echocardiography guidelines. Just to note that transesophageal echo differs from transthoracic echo in that it is considered an aerosol generating procedure which requires a different form of personal protective equipment. This is a summary slide relating to COVID-19 and cardiovascular complications. New specific recommendations are being developed in relation to the management of atrial fibrillation in patients with COVID-19. The key messages here are the interaction between the drugs used in the management of COVID-19, such as interleukin-6 inhibitors and antiviral agents interacting with warfarin, and the new oral anticoagulant agents. I'd like to thank you very much for viewing this presentation on COVID-19 and the heart. I leave you now with this final summary slide and a list of references, some of which I hope you may find useful. I also leave you with a final slide which asks the thought-provoking question: heart in COVID-19, is it the primary target or secondary bystander? Thanks again for viewing.